The following podcast is part of a certified educational activity titled The Immunotherapy Playbook for Resectable Non-Small Cell Lung Cancer: Real-World Challenges and Practical Strategies. Access the entire activity and complete the post-test at peerview.com/VCW860. Downloadable slides and practice aids are also available.
Hi, welcome. Good evening. Thanks to all of you for joining us. We're going to have a great discussion today covering the Immunotherapy Playbook for Resectable Non-Small Cell Lung Cancer. I am Gavit Woodard. I am a thoracic surgeon at Yale, and I'm very happy to be joined by Dr. Matthew Bott from Memorial Sloan Kettering and Jonathan Spicer from McGill University. So we're looking forward to a great program with you. So today we're going to be learning how to interpreting and apply the clinical evidence on neoadjuvant, adjuvant, and perioperative immunotherapy in the real-world setting, how we make our real-world patient care decisions. We'd like to build stronger multidisciplinary alliances that facilitate timely, effective, and safe delivery of immunotherapy and local therapies to the most appropriate patients with resectable non-small cell lung cancer. We do really want this to be a town hall format, so the questions that we are answering have been submitted in advance, and so we have several modules that we'll be going through where we've grouped things that you wanted us to discuss. So the first thing that we're going to talk about is optimizing the timing, selection, and sequencing of immunotherapy in resectable non-small cell lung cancer. I'm going to turn this over to John for a minute, who's going to run us through this data.
Sure. Thanks, Gavit. So we're at a stage now with maybe a little over 10 years into the initiation of the immunotherapy trials for resectable non-small cell lung cancer, and we're seeing overall survival data. We have positive overall survival in the PD-L1 high patients for adjuvant atezolizumab. We have positive survival data for pure neoadjuvant chemo-nivolumab, and we have several, and we have perioperative with the Keynote 671 data that were published not too long ago. So a lot of options, and obviously sequencing and timing become important. So perhaps central to all of this is who is resectable, and when should we decide when patients are resectable? Should we decide prior to any treatment, reassessed after a couple cycles, or you're not sure? Nobody is sure. I bet might be the most honest answer out there.
It's also very unanimous.
In fact, it's true. We are not sure, but it's open for discussion. So what are the borders of resectability? I think up until now, everything I've read that's been published has been primarily focused on framing resectability around TNM staging. So is the T size or invasiveness amenable to a resection? Is the nodal burden, whether it's multiplicity or bulkiness or invasion of the nodal component, contributing? And to what extent is there presence or absence of oligometastasis? What are the procedures that you might need to do? Are you ready and able to do angioplastic, bronchoplastic interventions? All of these things are contributory. And of course, we need good staging. Now that most of these first generation trials have been completed, we now have access to these regimens by standard of care, and we're seeing more and more real world data being shared from different centers. This is real world experience from the University of Pennsylvania, where they saw a surgical resection rate of 58% after chemo-IO. This is frightening data for me. And I'm wondering, maybe Gavit, Matt, do you guys have any thoughts about this? How do you guys explain?
I think Matt?
Yeah, I mean, I think that rate seems lower than maybe what we would expect, both based on the trial data and I would say personal and institutional experience. You know, I think resectability, we've talked at the conference quite a bit about resectability sort of being in the eye of the beholder. So I think there's a lot to be said for sort of individualized decision-making on the part of the surgeon, as well as the institution and sort of institutional norms. So I don't know if some of that comes into play here, or, you know, if there's some component of we have such high hopes for our chemoimmunotherapy regimens that, you know, we're believers now in sort of aspirational surgery sometimes, where we expect miracles from the perioperative therapy, and we'll just be able to go in and with ease remove the remaining part, and sometimes, unfortunately, that's not the case. So, in reality, probably a combination of things, I would assume. But again, very surgeon dependent, institution dependent. I think you have to take data like this with a little bit of a grain of salt, I would say. But
Fair enough. And here's another example of this, Jay Lee, and looking at Flatiron data. I'll draw your attention to the left, where about 167 patients in this study did not go on to surgery, and unfortunately, a significant proportion of them, 44%, didn't even make it onto radiation as some form of local therapy. Gavit, any thoughts about this?
Yeah, I mean, obviously, these are lower than the rates that we like to think of for patients who do make it to surgery after neoadjuvant therapy. And I think in this study, it's a little bit hard to know for sure because this is retrospective data not being prospectively collected, like what was the true intent for the patients who are being evaluated here. But, low rates of radiation use for patients who are not getting surgery. And it's tough to know because this is very different from what I think a lot of us would say is happening at our own institutions. But,
It's
obviously
also,
it varies.
I mean, it's also an abstract, so it's hard to know what the reasons were, right? You sort of need a little more granular data, I think, to get to the bottom of this, but we'll see.
Fair enough. This is real-world data from a French multi-center study looking at 56 centers across France, where the indication for chemo-nivolumab is only approved for for PD-L1 positive. So these are important considerations. You might have higher resection rates if you're only exposing to patients that are perhaps more likely to respond. But there, the resection rate was 88.4%. You can see very high R0 resection rates, 96.5, and a distribution of surgical procedures that's akin to what we've seen in most of the trials. So certainly encouraging reproduction of what's been seen in the trials, also true for T and nodal staging. So these are data in Quebec, Montreal data. Part of the reason I wanted to show this is that there's a lot of debate about whether we should or should not operate patients who have persistent N2. So if you have a patient and you restage them after induction and you think they still have N2 disease, should they still go on to surgery, or should you perhaps consider chemoradiation? And while the blue curve, which is the patients who do not respond in the N2 node in the nodes, have less good outcome, the outcome isn't all that different to what we would expect from CRT. And the surgical outcomes were acceptable. So this is about 3-year data, median survival for our cohort of about 180 patients.
It's hard in those patients because they're kind of a group that has the worst prognosis overall. They're not responding. We're trying to give them our best therapies, but there may be a group that no matter what you're doing, unfortunately, doesn't have a good prognosis.
Right.
All right, I'm going to cover MDT-BRIDGE for a little bit. So this is a study looking at this concept of whether or not can you start off with 2 cycles of neoadjuvant chemoimmunotherapy, reassess a patient who might be borderline resectable, and then if they do become resectable, successfully offer surgery. If they remain borderline unresectable or not resectable at that point, can they then receive some sort of local therapy like a Pacific sort of regimen after surgery so that all patients are receiving some form of local therapy? This was a phase 2 study design just looking at feasibility. And the data were pretty encouraging here. The numbers are small, but in general, the takeaway is that more than 95% of patients were able to receive some sort of local therapy, whether that was surgery or chemoradiation after 2 cycles. A lot of the patients who were felt to be resectable at baseline, 91%, went on to surgery. So these drop-off rates that we quote from all the other trials, 20%, 15 to 20%, that's really not what we're seeing when a patient starts off as clearly resectable at baseline. For those who are borderline resectable, still a large number of them, more than 80%, did go on to receive a surgical resection. And in the cohort that wasn't surgically resectable, again, high uses of radiation therapy in this group. So most patients are able to receive some form of definitive local treatment. And these are the R0 resection rates and divided by groups, whether or not it was a borderline resectable or fully resectable at baseline. But just showing that, we can successfully treat these patients, even those who are borderline resectable, give them a few cycles, see what the response is like, and then pivot our plans at that point. And we do want this to be more of a conversation. So, John, I'll go to you. So, this concept of borderline resectable is very hard to define. Is there a value in standardizing it? And how do we do that across different stages and different surgeon and patient and institutional preferences?
I don't think it's going to be easy to define because there's too many moving parts. When we wrote the protocol for MDT-BRIDGE, it was important that the patients be physiologically fit for the operation that was thought to be required for them to have an R0 resection. That was a determination made at baseline, which can obviously change if they respond well. But I hesitate to enroll patients into a neoadjuvant regimen if they're physiologically borderline for what I think might be required at baseline, because I find the risks are too great that we won't actually. I don't know. What do you think?
Yeah, and I agree. I think that's one component of it. I mean, I read this as more of like a sort of how do we define technically or oncologically resectable. I think you're talking about physiologic, which is important as well. So, there I think of things like standardizing the size of bulky lymphadenopathy or, T4 in what sense, from a purely size perspective or involvement of other, structures. So I agree with John. I think it's difficult. It's sort of an important question, but it's one of these things I think that's very difficult to pin down. And you kind of know it when you look at it, but putting it into words with criteria, I think is pretty challenging. So.
Right. I agree with that. And a technical resectable may be different from oncologically preferable, like a patient with chest wall invasion, sure, that can be resected. You start adding multi-station N2 disease to that, and it's a little bit less appealing.
Sure.
Mm-hmm. Yeah, I think probably as we move on in the future, we would hope to have decision trees that help us inform what the likelihood of an R0 is for a particular case, for a particular surgical team. But that's the challenge, is that one surgical team might achieve a certain thing and another might achieve a different one. And that's hard to equalize across.
Yeah.
Yes.
Are you guys doing at your institutions an MDT-BRIDGE approach, or kind of waiting after a few cycles in certain unresectable patients?
I wouldn't say we're doing
Borderline?
it formally,
Yeah.
but we sort of do it informally, I guess, right? Like we'll have a tumor board and everybody will sort of shake their head like, boy, that's tough. I don't know. And then, inevitably we decide to try, right? That's like the way that dialogue plays out. And a lot of times we get a nice response and it works out, and sometimes not, and we pivot. So it's not structured, I would say, in any way. I don't know if that's different at your places.
No, it's very similar. I think our usual is to do restaging exams after 3 cycles, because that's the regimen we have available. But when we have these cases where the surgeon is hedging or hemming and hawing, then, it could be a pancreas, or you're not certain, or just something that you feel might be too big of a bite to take, then we'll restage earlier and possibly switch gears.
Yeah, and I think there's, growing amount of data that can be the right approach for some patients. If biology is truly what's driving survival in a lot of these cases, that someone with an excellent response, you'd rather kind of go for it in that person.
The other thing I'll add is we'll always ask our rad oncs if they would consider a hypofractionated RT regimen after a full course of induction. So if they get 3 to 4 cycles of chemo-IO, does the disease look like it would be hypofractionated for, say, a 3-week regimen instead of the typical 6-week?
Okay, we have a question from the chat that we'll answer real fast. Should patients get 2 cycles or 4 cycles prior to surgery? I think the real question is 3 or 4. I think there is, getting to 3 cycles an important cutoff, but besides that, 3 or 4 would be our goal.
I think so. And then I think, the MDT-BRIDGE idea with the 2 cycles is interesting. I think we're all excited to see the data that comes out of our trial. I think the truth is that sometimes it may take more than those first 2 cycles, or it may take time to actually radiographically see substantial change. So I wonder if there's going to be sort of room at some point for doing 4 and then reassessing in patients who've had some response after the 2, but not enough. So I think it's very much a moving target. And I want to drill into something that you said earlier, alluded to. So after the checkmate data, I think there was a lot of excitement about the possibility of sort of downgrading the resections from pneumonectomy to lesser resections. So you made the point that you wouldn't necessarily rely on that when you're thinking about borderline resectable patients. Let's say they're not going to tolerate a pneumonectomy, but that's what they need right now. So would you still consider this sort of MDT-BRIDGE approach in that situation, or is that a deal breaker for you?
No, and I think it's acceptable. I think, again, it's a discussion with the team, with the patient, that they do have these two options in front of them, and that we don't need to commit them to one or the other necessarily. But I do hate going into surgery where I don't have a green light for a pneumonectomy, and I'm doing some crazy sleeve situation that's a stressful operation, but we still do them every now and then.
All right, I'm going to keep us moving. Lots to cover. Okay, so please answer this polling question. My preferred treatment approach to a biopsy-proven adenocarcinoma without EGFR and ALK alterations with PD-L1 of 1% in a 2.5 centimeter tumor with a positive level 11 node on EBUS 2A this is basically a situation of a small tumor but with N1 disease and low PD-L1 expression. Upfront surgery with no neoadjuvant immunotherapy, upfront surgery followed by adjuvant immunotherapy, neoadjuvant immunotherapy followed by surgery, perioperative immunotherapy, or I'm not sure.
Okay, good. Everyone agrees.
All right, you want to take this over, Jim?
Yeah, sure. So, okay. So clearly, we need to discuss more because nobody is sure what to do in this setting. These are the stage 2 data, actually a dedicated stage 2 manuscript led by Masahiro Tsuboi, who sadly passed away just a couple of months ago. But what I think is important to note here is that this is AJCC 8. If you're stage 2A, so these are the greater than 4 node negative patients, or 2B, N1, or T3 and 0 patients, you have equal benefit or almost equal benefit to the addition of perioperative immunotherapy over chemo alone. You don't really see any difference between stage 2A and stage 2B when you add immunotherapy. So if you believe that you should give stage 2B patients immunotherapy, probably you should consider it for stage 2A as well. The meta-analysis data on the outcome of EFS is strongly positive with a hazard ratio of 0.71, which was, just to remind everyone, the hazard ratio for adjuvant chemo in stage 2 is about a little under 0.8. And so now you're adding another 30% benefit over and above that. So I think it really is the judicious thing to do to consider neoadjuvant strongly in this setting. And this is unpublished data, but it's in the final stages of publication at Annals of Thoracic Surgery, looking now that we have overall survival data in the stage 2 cohort. And here the hazard ratio is 0.68 if we put 816, 671, and rationale 315. And there are most certainly no adjuvant immunotherapy data for this setting. So again, I think it is the responsible thing to consider, especially since the technical considerations are usually less in these patients. What is the meaning of stage in the era of immunotherapy? I think these data are compelling. Look at the gray curves. Patients with N2, this is in the 77T perioperative nivolumab trial, gray curves. You have a 45% EFS at 1 year in the N2 patients, and you have a 62% EFS in the non-N2 patients. But once you add immunotherapy, the presence or absence of N2 becomes seemingly irrelevant in this context. So nodal status may not be a strong stratifying factor in the era of immunotherapy. So should it really be dictating your choices? I'm not so sure. The data from 671 are a little bit different. This is from the Annals of Thoracic paper that just came out a couple months ago, showing the surgical outcomes as well as some outcomes by stage. And you do see a little bit more difference between CN0, CN1, and CN2. So it'll be interesting once these data get amalgamated to see to what extent nodal status really influences outcome in the era of immunotherapy.
The real takeaway from all that is kind of anatomic stage matters so much less in an era where we have highly effective therapies. And so whether it's you're talking about stage 2 or stage 3 with and without nodal involvement, it's really a pretty similar Kaplan-Meier survival curve in the group that's getting neoadjuvant immunotherapy.
Yeah, that's right. At least that's how I see it. Talking about some of these issues. So maybe, Matt, do you think nodal status be influencing your decision making? How does it influence yours?
I mean, I think it does to some degree. I think we've always been pretty aggressive in resecting patients with nodal disease, be it multistation, et cetera. I think our sort of bias has always been if it can be surgically resected, then we operate on those folks. I know that's not the same at every institution. I will say, obviously, we factor that in, with things like N3 disease. I'm not necessarily convinced that we're going to be operating on a large portion of those folks, even if maybe if they have downstaging, maybe not. But I do sort of think, at least in our mind, that if the disease is resectable, even from a nodal perspective, then we can remove it. Now, if it's a risky operation and you have 3 or 4 mediastinal nodal stations, and oncologically you don't know necessarily how much good you're doing the patient. Obviously, there's nuances there, I think, but I think in general, a healthy patient would tolerate surgery and it's resectable, then we usually go for it. So
I would agree with all of those points. And I think, to the point that was made earlier, if you are N0, there are certain patients that may not even have the opportunity to see adjuvant therapy, adjuvant immunotherapy, if they were to go straight to surgery. And so thinking that you might catch it on the back end if they were to benefit is not a reliable strategy in those patients.
So maybe to push you guys on that, when do you consider upfront surgery?
I mean, I wouldn't do it in a patient who has any nodal involvement, so even N1, I would argue that that is a patient that biologically is higher risk for having occult disease in other nodes. I think, a really small primary and N0 is kind of those buckets for me.
yeah, I think the N0 thing is a little sort of more challenging. I still try and do it. I did have one patient one time that was like a N0, and we gave treatment, and that guy had pneumonitis, and the surgery got delayed, and I was like, why don't I just take the thing out? But I think, and even when talking about the N1s, like you use the words like responsible and judicious, like, yes, it's the right thing to do. Sometimes it hurts a little bit because you're like, well, N1 disease in particular, right? Because I feel like oftentimes, even with N1, with no preoperative therapy, I can probably do the case minimally invasively, it will probably go fine, right? But I feel like hilar nodal disease is the one situation where it makes the resection maybe a little bit more complicated and does increase the risk of conversion. So you're right. It's judicious and responsible. That's the right thing to do. And and my practice has changed. With chemo, I probably operate on those people maybe up front a little bit more. But with the chemo-IO, I do think it is important. So I'm trying to be judicious and responsible too. So
Yeah, don't get me wrong. Those are annoying cases when they're all fused in the hilum. They're very tough. I guess the scenario where I'm doing more upfront surgery is for light smokers where I don't have a great NGS panel. Maybe even in a PD-L1 negative patient who's node negative, where it's a little bit. I'm not sold on the long-term benefits of the approach, but where I was very pro-neoadjuvant, there are some scenarios where I'm actually doing a little bit more upfront surgery, especially if I have adjuvant trials open, patients open to that, I consider.
I will say one other thing. There's some pretty ugly like adeno subtypes. So I had a couple cases of like SMARCA4 deficient, like dedifferentiated carcinomas that like blew through chemo-IO and were ultimately unresectable. Now, the small bit of data that's out there still says that those people respond most of the time, but I have taken 1 or 2 of those patients who were sort of right on the edge of being resectable to surgery up front just to make sure we didn't lose a window. So
Yeah, those are the cases that come up at our tumor board as someone who is easily resectable in this moment and maybe a never smoker. All the things that we say kind of correlate with the likelihood of a worse response or a non-response to immunotherapy. That's when our surgeons start getting a little antsy that we might lose a window.
Right. Oh, yeah. I think this is an important one. Like, what kind of touches on what we've already been discussing, the third one at the bottom there. How should decisions differ for resectable N1 with PD-L1 positive disease? I mean, my view is that PD-L1 is clearly a stratifying factor, so it might influence my decision a bit more than the nodal positivity. But do you guys think of that differently?
I mean, I think one number that I always like to bring up in our tumor board is that the checkmate data among PD-L1 0 patients, there was still a decent number of those, I think it's 17%, who had a path complete response. And that's lower than the groups with high PD-L1 expression, but it's definitely not 0. And so if those patients do get a path CR, you know that you're providing a real benefit to them at this point. And so I think it's really hard. We know there's heterogeneity among tumors and that our biopsies maybe aren't totally reflective of what the true PD-L1 expression of a tumor is. So for me personally, I don't use that alone to hinge my decisions.
Yeah. And I think one other place where we've found PD-L1 testing helpful is with a sort of locally challenging tumor like a pancreas, let's say, right? And you're trying to decide between old-fashioned like chemo-RT or chemo-IO. Sometimes we'll use that information, and if they have a high PD-L1, I feel much better about going the chemo-IO route. And if it's PD-L1 negative, maybe we sort of pivot there. So might be one other thing to add.
Good. A question. Well, I'll talk us through it. So my decisions for additional adjuvant therapy after neoadjuvant chemoimmunotherapy are made, 1, preoperatively, N2 disease, stage 3, based on the degree of pathological response, based on the degree of pathological response and the presence of detectable ctDNA after surgery. I'll be curious to know how many people are using those kinds of tests. Or you just let the medical oncologist decide and you give no recommendation. Okay.
All over.
Clear consensus. So 816 data on path response. So I think this has been pretty pivotal. We have amazing overall survival data for the PCR patients. No deaths due to lung cancer in that group. The few patients who had events, one had an ALK translocation, a couple others had radiographic calls, and this will come back a little later, of events, but were never treated subsequently. So a really impressive outcome, but not much difference between the curves in the non-PCR patients. So I'll ask you to remember that. We have nice data from Keynote 671 looking at outcomes in PCR versus non-PCR patients. And just to remind you, in terms of disposition, it's about a little less than half of the patients who've completed neoadjuvant and surgery who actually go on to complete a full course of adjuvant. A little more than 2/3 who get at least one dose of postoperative immunotherapy, and this is true for the other perioperative trials. So similar here, now we're looking at EFS, not OS, but we see huge separation between these non-PCR and PCR patients, but a fair number of events, somewhere in the 15 to 20% range for the PCRs, versus only 43% being event-free at 5 years in the non-PCR patients. So you remember those 816 curves in the non-PCR patients. We see much more separation in the 671 patients with a very impressive hazard ratio of 0.69. So even if you don't achieve a complete pathological response, immunotherapy seems to be helping these patients, and the forest plots are encouraging pretty much across the subgroups. These are the patient trajectories in the PCR category, and there was a really nice discussion by Mariano Provencio at ELCC who discussed these results that are presented by Margarita Majam, and he brought up a few important points that we should be mindful of in the perioperative area. Well, first is that there are deaths in patients without progressive disease. So not all of the events that we see are due to lung cancer, and that's especially true in the PCR category. So you need to be very judicious and mindful about the utilization of additional systemic therapy in this population. And the other thing he pointed out, which I thought was quite interesting and an important reminder for when we think of trial endpoints, is this rate of events in the PCR group. So if you look across trials, there is different rates of disease progression calls. And I'll remind you, these are done sometimes locally by investigators in some trials, and in other trials blinded by radiologists who don't know anything about the case. That's how you end up with an EFS event called and a patient never getting treatment. It's because there's a discrepancy between what the blinded investigator sees on the CT and how the patient's actually managed. And one of the things that Dr. Ferencio points out is that in 671, there's sort of a discrepant number of events in the PCR groups as compared to the other categories, where you have about 19% versus much lower rates in the other groups. So is that because there's actual events that are being appropriately called and the others are undercalling it, or is one trial overcalling it? this is important if you're going to make important therapeutic decisions. And it's why we kind of want to see the overall survival data, because it will help provide a bit of a reality check on this.
I was going to say, it would be interesting to see and important to see, because right now, I think we've all come to accept that if you have a path CR, we think that's an excellent endpoint for overall survival based on checkmate.
Right.
If this were to show something other than that, we might have to completely rethink our strategies.
Totally. And I was pleased to see that there's a differential view of what we should be, how we should be influencing the patient decision on these postoperative treatments. As a surgeon, I still think our role is quite important. While we might defer to our med oncs, I know our patients come to us for insights. And so that's why knowing these data is quite important.
So I'm going to talk a little bit about ctDNA and how this might influence our decision making. So a few things just to cover what ctDNA is, and a few points just about ctDNA in general. We have tumor-informed and uninformed assays. They work in different ways, with the tumor-informed being more sensitive to detect ctDNA in the bloodstream. If you're positive at baseline, what does this really mean? We know that the tumor is in situ, so this is really just detecting potentially DNA that is being shed from your tumor. The question is it DNA that's also being shed from other sites in the body? And we really don't know where it's coming from when we get a baseline ctDNA performed. When we look at clearance, and so this is now comparing patients who would have had ctDNA detected at baseline and then not detected or still detectable after surgery, and this is a subgroup analysis, and so the numbers get quite small if you look at the number at risk. So not tons of patients included in this analysis. But the point really is, if you do clear your ctDNA, that bodes very well for survival in the nivolumab and chemotherapy arm and in the chemotherapy arm alone. And if you don't clear your ctDNA, that's really a poor prognostic sign. And so it does kind of correlate with our path CR prediction, and this is overall survival data. Again, though, the problem is that the presence of remaining ctDNA or MRD after surgery is a poor prognostic sign. The challenge is the lack of it, or not having it detected, unfortunately still doesn't tell us very much. And there are patients who have no ctDNA, and this group can really have no path response or have a complete response. And so it's really challenging to know, if you're not detecting it, what that really means. And obviously these assays continue to improve, and so in the future we may have more sensitive things to detect it, but at this point it remains really investigational and exploratory.
I'm curious. I know what I think of it, but Matt, do you think we'll ever get a test that's so sensitive that it can see 5% residual disease?
I think we're going to get much better than what we have. Whether it gets down to that level of sensitivity, that part I'm less certain about. I think in my mind right now it's challenging, just because there's different assays, different sensitivities, not a whole lot really that's like clinically validated, I think, at this point from assay to assay. So the way that I think about it is, if it's positive, it's bad.
Yeah.
If it's negative, we don't really know, right? Is it a sensitivity issue, or have you really cleared? And that's the part that I struggle with a little bit. And admittedly, I can't say that we check it routinely, in these patients. I'm curious if you guys are actually using it, like how many people are actually doing it routinely in their practice. I'd imagine it's probably a minority, but what do you think?
We don't use it routinely.
Maybe by show of hands, anyone using ctDNA in their clinics? Yeah,
One.
Okay. No.
Not routinely.
Fair enough.
Well, it's a challenge because, the assays aren't even super sensitive in stage 1 disease. And so I have trouble imagining how across the board that you could detect kind of micrometastatic disease that may not be detectable on a CT scan at that point, how sensitive you really have to be in those cases. So this is an analysis that just came out from AACR. It's pretty fresh off the press for Checkmate 77T. And what they looked at in this study was patients of the subset who had detectable ctDNA at baseline. What percent of those cleared before surgery? And so a lot of the patients did clear. On the left, you see the nivolumab treated arm and on the right is the chemotherapy alone. So there's more clearance with immunotherapy prior to surgery. I would say the challenge is that among the group that clears, there's really a mix of path CRs and not path CRs. So this isn't a very good predictor of whether or not a patient is experiencing a pathologic complete response. And then of the patients who then later on after surgical resection had MRD positive disease, it's kind of one in each category. And so again, it's not very helpful. I would say that it's kind of a rare event. It's a poor prognostic sign, but the negatives are all over the place. So it's really hard to use this to guide therapy at this point, and the data is kind of limited at this point.
The other thing I'd add is that this is about a 400 and some patient trial, and you have 1/10 of about 10% of that. Well, sorry, 20% of that population that had sufficient material to do this test. So, these are complicated tests to execute, and it's hard to get point of care information on every one of your patients. These are expensive things. So until we have really robust data that helps us make decisions, I think these are still in the realm of research, right?
Yeah, I would agree with that.
Right. So what is something that we do that's point of care that's relatively easily accessible in most hospitals? CT scans and PET scans. So we'll talk a little bit about that. There's some nice data here from aging that was presented by John Haymack at ESMO in the fall. And the question they were asking is, does a radiomics assessment of the pre and post-induction CT inform the depth of pathological response, and does adding ctDNA information to that improve the prediction? So these are the numbers. Clinical information alone provide an accuracy, an AUC of 0.61 for PCR. So not great, a little bit better than flipping a coin. Radiomics alone was 0.78, so quite good actually. And this is just looking at the tumoral response, not looking at any nodal or anything else, in a guided way where you paint out the tumor before and after, and you apply some radiomic strategies to that. Interestingly, when you add clinical and radiomics, the model gets worse, and this often happens with machine learning. They can't cope with too much complex information sometimes. But interestingly, when radiomics are combined with ctDNA dynamics, so clearance at cycle 3, day 1, so just late mid neoadjuvant regimen, you get an AUC of 0.84. So while we talk about this, I'd like you to think, is an accuracy of PCR prediction of 0.84 sufficient for you to make clinical decisions or inform your approach in the OR?
It's tricky because that's just a hair higher than the radiomics alone. It's
It
not
is.
not contributing a dramatic jump there.
I'm glad you said that and I didn't, but I agree with you 100%. Nevertheless, when these are the predicted PCR and non-PCR curves from the model, and when you overlay the actual, it's not bad actually. So that's what a AUC of 0.84 looks like. It's pretty good at predicting the outcomes of these patients. So is this information sufficient to maybe consider de-escalation, all kinds of things you could use? And what could we do to further improve upon these predictions? This is a small study that we did out of McGill and the University of Montreal, where we looked at patients with pre and post PET scans. And there's a few other studies like it. Here, what we found when we did the ROC curve for PCR, we found that the threshold was 70% reduction SUV between the max SUV of the lesion at baseline to post-op, and that was to post-induction, and that was associated with an AUC of 0.89. So we were kind of surprised at how high that was. But and it actually influenced me and our team to start doing more post-induction PETs, because it would be nice to know if the patient is in PCR or not. If you're kind of considering your question of whether you should do a pneumonectomy or de-escalate to a sleeve or something, it's useful to know before going to the OR what the likelihood of that is. But the red circles are patients who are in excess of a 70% or greater SUV response, but who had residual disease. So there's still a fair number of patients with residual disease there that needed a resection. What is the role of ctDNA MRD assays after surgery?
All right, so there have been studies that have shown that ctDNA can be used to protect MRD, and certainly the presence of it is a poor prognostic indicator. Again, like we've touched on, I think that, when you don't have it there, it's hard to know what to do in those cases, but certainly MRD that is detectable on these assays is predictive as a poor prognostic biomarker. And so this is the Aegean data when we look at, when we do our first time point, the post-surgical landmark. This is when you would be starting adjuvant therapy. These labs were drawn cycle 1. And so if you had MRD at baseline, that was a poor prognosticator for who was going to do well or not well long term. So if you were ctDNA negative, those are the lines at the top, the good Kaplan-Meier survival curve for DFS. And then no matter what treatment arm you were in, being ctDNA positive when you were about to start adjuvant therapy was a poor prognosticator for disease-free survival.
I guess the other thing I'd add is it doesn't really differentiate between who does well with immunotherapy
Exactly.
and who doesn't. So we know it's bad prognosticator, but we don't know what to offer these patients.
And what to do with that information. All right, so we have some questions to address. So should adjuvant IO be routine after neoadjuvant chemo-IO, or do we use things like our path response, residual nodal disease, margins positive? How do you guys make your decisions for going forward with adjuvant therapy? Is everybody getting it?
No, not everybody's. I mean, at least I can speak at our institution. I don't think everybody is getting it. I think patients that do not have a path CR are the ones that are most likely to get it. I have a little bit of an issue with that because we look at sort of these subgroup analyses and these kind of things to make those claims, and I feel like it's becoming established without randomized data, which we may never really have, I feel like. But I would say that the patients without the PathCR are the ones that often do get it. I think using PathCR as a predictor is reasonable. It's tangible. It's quantifiable. The ctDNA, again, if it's positive, I think it's helpful, but I worry about de-escalating in patients who are ctDNA negative, just knowing that some portion of them really are not true, are not truly disease-free. So I struggle with that, I think, a little bit more, but yeah, I don't know what you guys.
John, what do you do?
It's very easy. In Quebec, we have no access to perioperative immunotherapy, so nobody gets it unless they're on one of our escalation trials. But I think if we had it, it would be a discussion. It would probably be only in non-PCR patients who are within that range of like 1% RVT to 60% RVT. I think the high RVT patients, you risk harming them actually by giving them more immunotherapy. I'd rather keep them free of treatment and prepare them for a first-line trial when they do recur, because they're clearly showing signs of not benefiting at all from immunotherapy.
Right. It's already, there's the group of patients who don't have a path CR, in general that is the cohort kind of facing potentially a worse prognosis long term. So you'd like to do something for them. We'd like to have at that point maybe a better therapy to pivot to that they might have a higher chance of responding to. But for now, right now, it's our choice to continue adjuvant therapy, which is our practice in patients who don't have a path CR.
Yeah, just to give you an idea, we had a patient who continued on adjuvant Pembro and progressed on Pembro. We retested her specimen, and because we don't routinely retest the surgical specimen, we found a RET fusion, and she had a brain met, and now we're starting her on TKI for that, and she developed some horrific pneumonitis. So treating people who are clearly not responding to immunotherapy sets them up for a world of complications down the road. And so just because we have nothing else to give doesn't mean we should give that
right.
thing.
I'm wondering what you guys think too, because there's been talk now of like reevaluating port in patients with persistent nodal disease, right? So we know that patients who have N2 disease persistent N2 disease post-treatment don't do very well, right? And in large part, well, at least in some part, those recurrences are in the mediastinum. Some of them are distant. It's sort of a harbinger of bad, biology disease. And after the LUNG-R trial, the port sort of fell very much out of favor, but there's been sort of murmurings, I would say, about maybe investigating it specifically in this context. I don't know what you guys
We've
feel
talked about
that.
it when we've had situations where there's been positive N2 disease. It's you don't have other things to offer at that point.
Yeah.
We have a trial, actually, not us, but the University of Montreal. Uda Baik is a radiation oncologist over there, and I forget what she called it. It's some snazzy name, and that's exactly what we're doing. So patients with persistent nodal disease, whether N1 or N2, or R1 margins, are being randomized to port or no port.
All right, we have some questions in the chat to cover, so thanks for sending these in. Should we broaden the definition of potentially resectable upfront or borderline T3, T4, or multi-station N2 cases, anticipating that they're going to have significant downstaging with chemoimmunotherapy?
Yes.
I think people are already doing this in real time as we've seen such encouraging results. This is kind of how our practice patterns are shifting.
Yeah, I think so. I think we do this all the time, and as long as the patient's ready for it, I think it's a good thing to do.
Yeah.
Radiation fields for T4 and 2 are huge and
Right.
have consequences.
Yeah.
Long-term ones.
Definitely.
All right, for planned pneumonectomy, does neoadjuvant response allow parenchymal sparing, and is it the benefit worth the perioperative risk? So, are you going to downstage your pneumonectomies with this? Is that worth the risk?
Yeah, I don't know that it's necessarily much of a risk thing for me. Like, I feel pretty comfortable that giving the preoperative therapy doesn't really increase the perioperative risk. I think there's been a lot of studies now suggesting that it's safe in the context of pneumonectomy. I just, again, getting back to what we were talking about before, if you go into the operation in a patient who can't, or into the treatment paradigm with a patient who can't tolerate a pneumonectomy, and you're really hinging on that sort of lesser resection idea, I still worry a little bit in that situation about how realistic that is. So I don't think of it from a risk perspective. I'm pretty comfortable in that sense. It's more just about realistic expectations as far as what sort of operation you can do. So
Yeah. I mean, we the same try to do very few pneumonectomies, but the data on the pneumonectomy patients is really, really good. So I think that's why I like to have as much information as I can about the probability of that. I'll do a lot of frozen sections in the operating room before I convince myself that we need to do the pneumonectomy. But when you do and the patient's fit for it, it's a great operation.
Yeah, I think in this space specifically, it'd be really nice, and we're not there yet, but to have great predictors of path response, because you hate to do a pneumonectomy for someone that has then had a complete pathologic response. This was brought up at a session earlier today. You're basically trading one disease for another at that point, and so trying to identify the right patients for it is key. All right, persistent N2 disease after induction. What do we do with that? Is that still going on to surgery, or do you pivot at this point to a Pacific approach?
Well, I asked the patient, would you like me to do this VATS lobe and you'll go home in 2 days, or would you like me to send you to the radiation oncologist and spend 6 weeks coming in a hospital for the next month and a half? Most of them will say that they want the lobectomy. So that's how I approach it.
I don't play it out quite that way. I don't present it to them quite that way. But I agree. I made the point earlier that I think if the disease can be removed, then we're pretty aggressive about removing it. So that applies to persistent N2 as well.
It's probably maybe even an area where surgery becomes more critical, because these patients are resistant to the therapies you're giving them that may predict their resistance to radiation as well. And so, in that situation, surgery may be your best chance at clearing some of those nodes.
Yeah.
Okay, squamous versus non-squamous are subgroups deriving different benefits. They also break down stage 2 or 3 high tumor burden.
I think the important thing, and the reason we're seeing maybe some differences between the two histologies, is that non-squames are enriched for driver gene alterations that make them in the subset immunotherapy unresponsive. So whereas that's less common in the squames. So I think it's more about doing NGS and understanding as much as you can about that patient's tumor.
All right. Okay, we're going to keep things moving. All right. Multidisciplinary strategies.
All right. So the case that we have is a 75-year-old female Has some comorbidities, some coronary disease on Plavix, actively smoking. It's always a sort of difficult situation. Presents with a right lower lobe mass. Came in with chronic cough, gets an x-ray, 9-centimeter right lower lobe mass, gets referred to medical oncology, has some weight loss. PFTs are decent, I would say, but somewhat frail in appearance. So seems like maybe we're sort of alluding to, from a functional perspective, a marginally resectable patient just physiologically. Gets a CT scan. We'll see the images in a second. Large necrotic right lower lobe mass, basically going from the atrium to the pleura, big tumor, some bronchial obstruction in the lower lobe. Now, this is where things get interesting. A few other nodules. So there's a nodule in the left lower lobe, and then a couple additional nodules in the right lung, and then some possible hilar adenopathy. So you're already getting the picture that this is a pretty substantial tumor. So now we have borderline physiologic patient with sort of oncologically challenging or questionable maybe resection. All right, so PET scan basically confirms all of those things I told you. Big tumor in the right lower lobe, couple additional lung nodules, and then this potential for hilar adenopathy. The brain MRI is negative. So these are some of the images from the scan. So you can see pretty sizable right lower lobe tumor, some central cavitation, probably some necrosis there. Can sort of get a sense of maybe the hilar nodal involvement there at the heart border. So again, pretty significant disease. And then in the top middle, you can see a satellite nodule. I think that one is in the I guess that's in the upper lobe, posterior segment of the upper lobe, and there's also a satellite nodule in the superior segment of the lower lobe, and then this additional lesion in the left lower lobe on that left side you can see in the bottom middle.
Definitely an example.
Sorry, no, go ahead.
Good example of a borderline resectable case.
Yeah, if you're going to pick a borderline case, this is like the extreme of borderline. Like, yeah.
Someone didn't tell Dr. Stiles that this is not the oligo-met session.
Right.
The neoadjuvant.
Correct. Also would fit other places maybe. Okay, so based on all of that, about how you would potentially treat this patient, options would be things like do a liquid biopsy and just treat this as stage 4 disease. Bronch and EBUS. I would include maybe robotic bronchoscopy to try and biopsy some of those nodules. CT-guided IR biopsy of the satellite lesions. VATS, combination approaches. Let us know what you think. Okay, so again, like pretty well-distributed options. Interestingly, nobody actually said that they think this would be stage 4. I would bet that there would have been some folks saying, forget it, this is not, I guess we're maybe mostly surgeons in the room, we want to take this out. So bronchibus, biopsy of some of the satellite lesions, I think all reasonable things to think about. So in this particular case, they decided to biopsy some of the additional lesions. So biopsied the left lower lobe nodule. So now on pathology, basically everything is squamous. So the tumor in the right lower lobe is a squamous. There's a right lower lobe satellite nodule that's biopsied that's squamous. So potentially intrapulmonary metastasis there. So T4. And then all of the lymph nodes sampled, interestingly, during the EBUS were benign. Okay, now perhaps you could argue they couldn't get out into some of those more distal hilar nodes. So that still, I think, is an open question, the nodal status. PDL1 on the left-sided nodule. So they sampled the left side, which was squamous also, but I'll show you some genetic data in a second. PDL1 on the left side was 50%, and basically PDL1 negative for the primary tumor in the right lower lobe. This might be hard to read, but this is the path report, basically saying what I told you. Nodes are negative, and squamous cell carcinoma in at least 3 places in the lung. What do we recommend for this patient? So definitive systemic therapy. So is that enough for you to say that this is stage 4 disease? Definitive chemo-RT followed by immunotherapy. Neoadjuvant chemo and immunotherapy followed by surgery. Neoadjuvant chemo-IO, and then sort of decide on local therapy based on response, sort of an MDT-BRIDGE approach. Clinical trial, that's sort of vague, but you could pick that, or I'm not sure. Okay. Yeah, so people like the bridge idea, right? So neoadjuvant chemo-IO and then decide local therapy based on the response.
I think that's reasonable. There's no nodal disease, so I think when you first look at the images, seeing contralateral nodules get a little concerning for metastatic disease. In the absence of any mediastinal nodal involvement, we start thinking that most likely second primary perhaps, but we would do sequencing, especially in adenodes.
Right. So squamous is tricky too, right? Because you can't really use morphology of the squamous to separate primary versus second primary versus met. So that's where genomic testing would really be helpful, and you'll see some genomic data in a second. And the nodal thing I think is still a little bit up in the air, right? We've all seen these like EBUS reports that have negative nodes, but there's like a node in the hilum that's like ridiculously PET-av, and you're like, I don't know. So I think that N1 thing is still on the table. Let's see. Okay, so bottom line here is that genetic testing of the left lower lobe nodule is actually different. The mutational profile is different than the primary tumor in the right lower lobe. So the left side has an RB and a P53 mutation. The right side has a different P53 mutation and a PI3 kinase mutation. So suggesting that what's on the left is a separate primary from what's on the right. So you could argue now you're dealing with two primaries, obviously the left more advanced, but now maybe a T4N1 situation. So that's what the group did. T4N1, they staged this woman as, discussed her at tumor board, and sort of agreed with the course that I think most people were in favor of, which was give some best systemic therapy up front and then hold off on a decision about a definitive local therapy based on response. Interestingly, here we were talking, so they opted to go 4 cycles just from the beginning. At least it doesn't say that there was interval imaging performed. Maybe there was, and we just don't know it. You could argue maybe you could have given 2 repeated imaging to assess for a response at that point, just to give you a better indication of where things were heading. Anything to add from you guys?
I think this is an elegant use of sequencing to sort of figure out better what's in front of you.
Okay, so you can see she had a nice response to treatment. Otherwise, we probably wouldn't be talking about it in the conference here. But shrinkage of the right lower lobe tumor, now about 6 centimeters or so. The satellite lesions in the right lung responded as well. Interestingly, the left-sided lesion did also, even though it was genetically unrelated. And there was improvement in the lymph nodes also. So the patient underwent surgery, had a robotic right lower lobectomy, wedge of that posterior lesion in the upper lobe, and then a lymph node dissection. Interestingly, there was a complete response in the primary tumor. However, some persistent nodal disease. Now, interesting that the EBUS, the nodes were in the mediastinum were all negative. This one had a positive level 7 on final pathology. So there is, the potential for false negative rates in terms of your mediastinal staging, but still overall a nice response to treatment and a complete resection. This is the postoperative X-ray. And what do we do from here? So this gets to what we were talking about earlier, persistent N2 post-treatment, nice response in the primary. So adjuvant immunotherapy, some folks not sure. I think that's definitely reasonable in this situation. What do you guys think? So you got to treat the left lower lobe thing, right? At some point, you can either operate on it or radiate it. But I think the crux of this question is like, what do you do about the persistent N2?
Yeah, I think this is probably a good indication for continued immunotherapy. We've looked at our patients with these discrepant results, whether they've had an MPR or PCR in the primary, but persistent nodal disease, and their outcomes are definitely, and that's been published from some of the trials as well, are not as good as if you have a good nodal response. So I think some continued therapy there. They're partial responders. It makes sense.
So you would do adjuvant IO?
Yeah, and I think SBRT to the
left side.
That's probably that's what we would do as well. I mean, the focus was very small, 2 millimeters in level 7, but I think it's a harbinger that there could be other spots in other places, and it's not a path CR if there's still disease in the lymph nodes.
And not enough evidence to support port yet, we think.
Right? I don't know.
You're already doing SBRT. I don't know how it affect the the total plan, but we're doing the trial, so we'll let you know.
We'll find out. We'll find out next time. All right. Okay. I guess we're going to any additional questions from the group. I think that's it for the case.
We have some in the chat that we can cover in this moment. So how reliable are post-neoadjuvant imaging biomarkers for predicting resectability or path CR? Should we be proceeding to surgery in stable partial responders or only in those with a strong response? I think we kind of covered this in general. I mean, my take on this would be if you're not responding well and you were initially surgically resectable and remain pretty clearly surgically resectable, a lack of response is really the reason why you should be going to surgery. Now we need to go and get all that unresponsive disease out.
Yeah. Go ahead, Joe. I'm sorry.
Well, I mean, it's a tough one. If you believe that local regional therapy is important, which is I think an open question, then I think you should operate on them. All the hazard ratios for all the trials are most favorable in patients who have surgery. So I think for the time being, you got to operate.
I agree.
All right. Should we avoid neoadjuvant perioperative IO and PD-L1 negatives, especially those with low tumor mutation burden, favoring surgery first and followed by adjuvant? We touched on this too.
Yeah. I mean, we don't make treatments about neoadjuvant treatment based on the PD-L1 status. I mean, I think it's an interesting thing to consider just when you're trying to gauge the likelihood of a response. But as I think, Gabby, you pointed out earlier, there are PD-L1 negative patients who do respond, so it's hard to know.
Yeah.
I think maybe one thing I would add here is that case, actually, I just came to my mind, this case, PD-L1 negative on the...
There's like 1%.
Or less than 1, or whatever, low.
Less than 1.
Low.
Yeah,
On a
basically zero.
squame, probably the best first systemic therapy is not chemo-immunotherapy or whatever. It's ipi-nivo chemo. The stage 4 data are most strong for the addition of CTLA-4 in these negative patients. So at our center, we probably would have taken advantage of the PD-L1 low, the clinical picture of metastatic disease to start ipi-nivo chemo, 9LA regimen, and then consolidate after that. And we've done that on a number of patients. Remarkable responses. I think this is one setting where CTLA-4 plays an important role.
Yeah, I would just say maybe that's not like I haven't seen that approach much, so I think it's an interesting idea, but I don't know that would be. Would you say that
No,
was like
it's not
standard of care?
No,
I guess
no.
that's what I'm getting at.
No, but I think if you're,
I just don't want people to come away being
No,
like,
I get
"You should do this."
I get it. But the point I'm trying to make is that we're in these settings, we're not far between, oligo consolidation for stage 4 and neoadjuvant for stage 3.
Right.
It's like it's the
shades of gray.
the same thing. So if your oncologist thinks they have a better first line option than what you would be available in a neoadjuvant perioperative setting, maybe that's the preferred option.
All right. Do we get ctDNA pre-treatment? My quick answer to this is no.
We don't usually.
No.
Should everyone get pre-treatment? I know the same one, ctDNA. Does insurance even cover this?
Not in Canada.
I think it's covered by the company at this point.
you can get it. I think it is covered initially, at least for patients with more advanced disease. I don't know quite so much about the early stage setting, but it usually will get covered. Whether it's useful or not is a different question, but I think
right. And then does it just add stress if that's positive? Or I think, situations where we've talked about, let's say you're using it even outside of this setting to monitor someone for recurrence and you get a positive result, but there's nothing on imaging to treat. How do you even know if this is widespread metastatic recurrence? Is this some local, easily treated staple line, surgical node? I think it's really hard to know how to approach those patients, even those who may have it without any radiographic data. All right, after neoadjuvant chemo-IO, residual disease is present. Are survival and recurrence influenced by the presence of either the tumor, lymph node, or involvement of both? I think we kind of covered this in this case a little bit. That, to really call it a path CR, you need clearance in both.
Agree.
All right, we're kind of running out of time. One final question here. What kind of patient the panelists think have the highest risk to cancel surgery? Bulky N2, multi-station N2, invasive N2, T3, T4, and then 4 3 cycles is a long question, are all the same, depends on response. So anyone that is clearly unresectable or kind of too high risk to put in this category for you guys based on N2 disease, bulky invasive?
Yeah, I was thinking sort of the bulky and invasive are sort of a bad combination.
Yeah.
I feel like if you feel like the subcarinal node is like invading the carina, like that's probably not a situation where I would like blast forward with a shot at surgery. So I think that's probably would be the most concerning to me, but I don't know if you guys.
We had a case like that at our institution, and then in the OR, couldn't get a negative margin.
But that's not canceled surgery. You took a go at
You
it.
explored. You tried.
I mean, for
Shot,
me, I
yeah.
think it's frailty more often than not. I would say that's the most common thing, is that we were overambitious about the fitness of the patient, and then we found ourselves with an unfit or excessively complicated patient after systemic to consider surgery.
Great. Excellent. Well, thank you, everyone, and thanks to our panelists today. It was a really great discussion.
No problem.
Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported through independent educational grants from AstraZeneca, Bristol Myers Squibb, and Merck Co. Incorporated, Rahway, New Jersey, USA. To access all materials for this activity, visit peerview.com/VCW860.